Good afternoon, and welcome to the second in a series of Samson Gaines webinars and discussion groups on crisis response. This second webinar, Designing a Law Enforcement-Friendly Crisis Services, will feature two exceptional communities in law enforcement crisis services collaboration. I'm Dan Abreu, and I'll be your moderator. Since the deinstitutionalization began in the 60s, the role of police as street corner psychiatrists has been discussed. Most states have embodied in their mental health code the duty of police to respond to mental health emergency. Too often, in many communities today, due to a lack of resources or crisis care partnerships, police response is hampered and can often result in arrest. For those familiar with the sequential intercept model, the police role in response to crisis is referred to as intercept zero. Many communities, often due to the development of police crisis intervention team training, have developed strategies to divert individuals with mental illness who commit less serious crimes by strengthening partnerships between law enforcement and crisis services. This diversion role is referred to as Intercept 1. Today, we will hear from two communities that form critical law enforcement crisis services partnerships to improve response to mental health crisis and to provide for increased diversion options for persons with mental illness. The views and opinions and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Substance Abuse and Mental Health Services Administration or the U.S. Department of Health and Human Services. A couple of housekeeping items. There is a chat box down at the bottom corner of your screen, and throughout the presentation, feel free to enter questions there as you wish. And at the end of the presentation, we will try to address as many of these questions as time permits. In addition, following this webinar, we will host a discussion group to allow for more in-depth discussion with our panelists. Please note, participation in the discussion group will require you to terminate your computer and phone connections to this webinar. A new link and phone number will be provided at the conclusion of this webinar to join the discussion group. This webinar is being recorded, and slides will be available following the presentation. I'd like to introduce our first presenter now, Candace Allen. She serves as Senior Director of Adult Intensive Mental Health Services at Helen Ross McNabb Center, overseeing the center's crisis division, which includes the mobile crisis units for both children and adults and the crisis stabilization unit, the Behavioral Urgent Care Center, victim services, including sexual assault and domestic violence services, and the Intensive Outpatient PAC program. She also serves as the Knoxville, Knox County, University of Tennessee Crisis Intervention Team Training Coordinator. She has fostered partnerships with the Knoxville Police Department and the Knox County Sheriff's Department and expanded services to criminal justice liaison, criminal justice case management, and jail-based services. Our next presenter, co-presenting with Candace, will be Captain Don Jones, who is a 33-year veteran of the Knoxville Police Department. During his career, Captain Jones has served primarily in the patrol and training divisions of the department. He currently serves as the patrol division captain. In that capacity, he is in command of all special operations units in the department and responsible for planning and responding to all major events. He is a member of the Tennessee Law Enforcement Training Officers Association and the Association of Law Enforcement Emergency Response Trainers. Following the presentation by Captain Jones and Candace Allen will be Margie Belfer from Tucson. She is a psychiatrist and national leader in quality improvement and behavioral crisis services. She is the Chief of Quality and Clinical Innovations at Connections Health Solutions in Arizona, which provides 24/7 access to mental health and substance use care throughout the state. Dr. Balfour is an assistant professor of psychiatry at the University of Arizona and named Doctor of the Year by the National Council for Behavioral Health for her work at the Crisis Response Center in Tucson, Arizona. She has co-authored the book, People with Mental Illness in the Criminal Justice System, Answering a Cry for Help. She also serves on the board of directors of the American Association of Community Psychiatrists, the American Association for Emergency Psychiatry, and the National Alliance for Mental Illness in Southern California. Co-presenting with Dr. Balfour will be Sergeant Jason Winsky. He is a leading expert in the field of law enforcement approaches to mental health and substance use. He has been with the Tucson Police Department for over 15 years, helped create the mental health support team to address the needs of high-risk individuals with mental health challenges, which has grown to a team of over a dozen officers, detectives, sergeants, and clinical co-responders. He is the co-facilitator of the Pima County Regional Crisis Intervention Team Training Program and a mental health first aid trainer, and has trained thousands of officers across Southern California. Turn the webinar over to our first panelist, Candace Allen and Captain Jones.
Okay. Thank you, Dan. Captain Jones and I are very grateful that we have the opportunity to talk to you all today. Before we get directly to our topics of behavioral health and law enforcement working together and how do we make that happen, we would like to talk a little bit with a brief overview of our agencies and departments. You want to start first, Captain Jones?
Thanks. The Knoxville Police Department is responsible for all the functions inside the city of Knoxville, which is in Tennessee. It's roughly 100 square miles in the center of Knox County. Population inside the city is 185,000, according to the census. But it's also home to the University of Tennessee and several international corporations and TVA, Tennessee Valley Authority, which brings our daytime population up closer to 300,000 when everybody's coming to work. The police department responds to approximately 260,000 calls from citizens a year, and we currently have 378 sworn officers. 90 of those are CIT trained to respond to mental health calls 24 hours a day, 7 days a week. Our remaining officers have received 40 hours of training on dealing with mental health crisis in their basic recruit school, as well as we have ongoing training with our in-service, which is a vast improvement from when I came on 30 some odd years ago.
So, for myself, I work at the Helen Ross McNabb Center, and we are a regional nonprofit behavioral health center in 29 counties in East Tennessee. The services that we provide include mental health services, addiction, co-occurring, and a wide array of social services as well. We have everything from baby court to geriatric and senior housing opportunities. I think if I step back, I think one of our main focuses is, and always has been, that we always try to look for gaps in services for those who have the most needs with the least resources. And this certainly falls into criminal justice programming. We have our basic clinics, and residential programming, but we've always focused on community. We have a lot of services in jails, in schools, in courts, in hospitals, and provide a lot in individuals' homes. So this philosophy, I think, of community-based focused and relationship-focused, because we also are very dedicated to establishing and maintaining partners in the community, kind of leads us to the next slide of agency commitment. I think it really positions us well to provide programming for criminal justice individuals. For 35 years, Helen Ross McNabb has been in the jails or really championing decriminalizing mental illness and addiction. It's more or less in our DNA. But we also, I think, if you make something work in regard to working with law enforcement, you've got to have the organizational commitment and support from the top down. And we have that. I think it's also important to carve out a criminal justice division in addition to your other divisions in your agency, because I really think this work is not for everybody. Not everybody is kind of geared towards these services. And then I also believe that even within that, you have to have champions within your agency that will keep it going. I think of Captain Jones on the KPD side. He has always been a champion in regard to establishing the relationships and getting these services out into the community. So in working with law enforcement, you just don't fall into that either. I think you have to earn it. And by doing that, you have to have an agency that's willing to develop those relationships, understand the culture of law enforcement, being flexible, being able to engage when those opportunities present themselves. And you need to be able to say yes when those opportunities are presented to you. A long time ago, Captain Jones, when we first started our crisis stabilization unit, said to me, you tell these cops no when they want to bring somebody by, then they're going on. They're not coming back, and you just got to understand that. That's the way that it is. Don't take it personal. That's just the way that it works. So I think you've got to be able to really work that way. Captain Jones, do you have anything to add on that?
I think it's an interesting marriage, if you want to call it that. Mm-hmm. The two agencies that are probably in any community that are going to be most impacted by mental illness are your mental health professionals and law enforcement, because we're working 24 hours a day, 7 days a week, and if something's a crisis, then everybody knows our phone number. We did a real good job about 25 years ago teaching them our phone number, and everybody knows 911. So we were behind the curve years ago dealing with mental health crisis. We've caught up in the last decade or so, and it's been a really big help to work with Helen Ross McNabb and them educate us on mental health issues that maybe we weren't aware of, and then we educate them on police issues and procedures and legal issues and constitutional issues. And if we're all willing to sit in a room and work through those issues and the problems that arise from them, then it becomes a very effective organization.
Thank you. So I next just want to talk a little bit about the Behavioral Health Urgent Care Center. Just to kind of give you a basis of what we'll be talking about for the rest of the presentation. So I'm going to refer to it a lot as the BHUC. That's what if I say that, that's what I'm referring to. The main thing that I want to get across about this is that this is a true jail diversion program. 100% of the referrals to this program, they are law enforcement. This is a program where individuals that have been arrested are given an alternative to jail via treatment. So it is not a drop-off by law enforcement, to our crisis stabilization unit or to a walk-in center. These individuals have actually been arrested. There are 9 misdemeanors that were as a result of meeting with our key stakeholders and the Attorney General, and decided that there were 9 identifiable misdemeanors that we would accept at this program. And so once the arresting officer brings the individual into the BHUC, we also have a policing station on site, because there has to be an exchange from officer to officer. And so we do have police station there to receive the individual from the arresting officer. At that point, there is an initial screening that's done and completed by the nurse and the master's level clinician. And that officer, the arresting officer, is usually back on their way within 5 to 10 minutes is the average. And so once that occurs, then we'll do more an in-depth assessment and admission process. Once they are on the unit, the services that are available to them, there's a prescriber that can meet with them for every single person that comes into the program. They will do an evaluation and prescribe if applicable. There are opportunities for individual and group counseling there as well. I think one of the main things that stands out, and one of the things that I think that we're really good at, is the holistic discharge planning that we do. We don't have these individuals long. It's 23 hours, but we can get a lot done in meeting and talking with someone and deciding what are the gaps, what do we need to help them access, moving forward. So maybe we can break the cycle for them or help them break the cycle. It's very interesting. The population that we discovered by opening this program was not who we thought it was going to be. We thought we would see people that we knew that were in our jails, that were in our clinics, or in other criminal justice programming, and that just was not the case. This was almost like a lost population that was maybe inner city, that was in and out of jail very quickly, that nobody really could get a hold of them. They're, for lack of a better word, they were kind of a slippery population that we just became aware of. And some of them had even 600 arrests in their lifetime, but they were just in and out of jail and were really not already in services at all. So that was really something that we didn't expect, and gave us an opportunity to really start people in a process of recovery. They had never really been able to start that process previously. Another thing that we changed this past year is that we have increased our case management and changed the program as well for people that want this kind of service. We have 5 case managers. One of them is a SOAR case manager to help people get on their benefits or help them establish their benefits. And then we're under more of a FACT case management model, forensic assertive community treatment, including a peer specialist. So it's more intensive. And so those individuals can access those services because probably about 65% are uninsured, and over 50% of them are probably homeless. So you can imagine the kind of barriers that, to accessing treatment are in front of them. The next slide has to do with the foundation and our key to success. And I'm going to turn this over to Captain Jones to talk about here in just a second. But before we get started, I've got the leadership buy-in with common goals. And I put tenacity here because it took us 10 years to get this program started. I think we wrote about 4 RFPs and finally were able to get it funded. So for all of you out there that are frustrated and trying to get something going, don't give up because it can happen. And I also want to thank Dan and the individuals there because through a previous grant that we had with an early diversion grant, we were able to have a sequential intercept mapping in our county and city, and I thought that was very, very helpful, as well as getting leadership to come in and a lot of different individuals, I think, which helped to kind of move the BHUG forward. You want to talk a little bit about that process with the key stakeholders?
I think that is probably going to be the most difficult thing you deal with as you're trying to build this partnership. Candace talks about it took us 10 years to get this. I spent since 1997 trying to get some kind of process going. And you're going to run into some cultural issues within law enforcement where the first thing out of their mouth is, this is a criminal act. We deal with it in a criminal way. That we're not mental health workers. And you'll get that from your leadership in some cases. And I dealt with that for at least a decade before I was able to start working with Helen Ross McNabb a little more. And we started making some of that headway. But you have to look for opportunities. And one of the opportunities that I found as I was battling this over the first 15 years was you always look for any opportunity to bring up, hey, we can do something different here and affect this. And one of the things we ran into was a jail overpopulation issue. And the jail here was put under a consent decree by the federal court because it was overcrowded. And I took that as an opportunity to bring up that, hey, we could divert people if we set up this system to try to get some of those folks out of the jail before they ever go in and affect those numbers some. And then you start getting buy-in because you're showing where it's going to benefit them. And then the next thing you run into is you're going to have to give me numbers on this because a lot of leaders are numbers driven. And we were fortunate enough to get a grant early on that we worked with Helen Ross McNabb with to look at a particular group, which would have been our prostitutes, and rehabbing them. And we were able to show numbers where we could reduce jail time if we gave them some kind of mental health treatment. And I was able to go to the leadership then and say, here are your numbers that you were looking for. And yes, we can make this work with other charges as well. And that kind of piqued their interest. And then we put together working groups that included the chief of police, the sheriff, the attorney general for the county, and then the behavioral health CEO. We all got together in a room where we started working through some of the issues we would have. And that was we were able to get it started that way, and at the same time look for funding from the state. And we were able to do that and to get us off the ground.
So in the interest of time, I want to go also to the next slide, barriers, solutions, and lessons learned. So, we, as previously stated, we had the major stakeholders, and then we had monthly meetings as well, the BHUP group meetings, and those were people that were more, I put down, kind of boots on the ground. These are people that were close to what was going on and doing a lot of problem solving. So I kind of wanted to talk about some of the lessons that we learned. Just first starting off with the assessment and triage, access to the program. When we initially started, I believe that we missed the mark, with law enforcement being the major referral source. I really think that, they don't have DSMs in the car, in their seats next to them. And so we were relying upon them to be the mental health experts and make those referrals. And that just went south. It did not work. And so and they would call in at some points and we would have to say, no, this person is not eligible. And we already know how that no goes. So that did not work. So we had to look at that and try to see what can we do to change this. So some of the solutions that we came up with, and I will attribute most of the solutions to Captain Jones, in those meetings. We decided that we would give daily reports from the behavioral health individuals sent to law enforcement because we could tell who was coming into the jail through our 24-hour jail list, and then he would check those out and see whether or not, did the officers miss that person as far as bringing them over, and so we would process that out. And then the biggest impact that we had, you want to talk about that a little bit? I think we talked about
Which impact are you talking about?
the one about when you decided to bring the individuals on the wagon.
We actually made a change to even take that decision-making process away from the officers altogether. On the 9 charges that we have, we just made it a stopover going to the jail to go by the BHUC and have them assessed there to see if they would be eligible for there before we went to the jail. and that seemed to help our numbers a little bit.
Yes.
We got a lot more people there that way.
Helped it significantly. So I think that's just part of having those groups and working together and coming up with those solutions. The other thing I would just say in closing, you know, this was totally different than anything we had done before. You know, we had worked with law enforcement. We had, you know, they dropped individuals off to our facilities. You know, CIT, other programs, like I said, that we worked with, but never before did we have law enforcement located within the building. You know, that's the reason we were married to them. We were living under the same roof, and that was a totally different perspective, and it was bumpy. And it was a little difficult at the very beginning to understand where all those roles were. You know, this wasn't a jail. This wasn't, you know, just the law enforcement side of that, you know, 100%. And then backing off of that and developing all of those protocols in the mental health, you know, and the licensure requirements that are different than a jail, and understanding all of that. So, but we stuck with it, and we, you know, compromised, and, you know, we still have ongoing things that we still address as to the state. This is a new program. It's only about 2 years old, but we are still working on it, and, you know, have seen a lot of positive outcomes as a result. And I want to be mindful of the time, so I would like to turn this over to Margie at this time. Thank you.
So Jason and I are going to talk about what we've been doing down in Tucson. And first I want to start with kind of the centerpiece of our crisis system down there, which is the Crisis Response Center. And this was built by Pima County using bond funds back in 2011. They asked my organization, Connections, to come run it in 2014. So we've been there since then. And the impetus for doing it really was from the county wanting, because they're responsible for both the jail, obviously, but also the county hospital and the emergency room there. And so they really wanted an alternative to jail or the emergency department or hospitals for people with mental health needs. And currently we serve about 12,000 adults and 2,400 youth per year. There's both a separate adult and youth units. And it really was designed to be the law enforcement receiving center with from the beginning, to have a no wrong door approach, meaning that we don't exclude people for being too agitated, too acute, too intoxicated, for being voluntary or involuntary, or their payer, or things like that, which I'll talk about in more detail. The services include, for both adults and kids, there's a 24/7 urgent care clinic. So this is where anybody can walk in off the street, or their clinic can bring them, or their family can bring them, or the mobile team can bring them. For people who they're new to town, they need to be hooked up with services, or they've missed their appointment and now they need a med refill, or they're starting to decompensate because they missed their appointment. So these are people who can get their needs met in a clinic setting within a couple hours so they see like a licensed therapist and either a psychiatrist, nurse practitioner, so we can get them in a couple hours. The heart of the operation is really the 23-hour observation unit, which I'll describe in more detail in a few minutes. But it is where the most people who would normally go to a hospital or an emergency room, we are able to treat them overnight and really try to do aggressive crisis stabilization with them. We have the capacity for 34 adults and 10 kids. And then there's a short-term subacute inpatient unit. We have that just for adults with the 3 to 5 length of stay for daily to people who need to stay a little bit longer. And then we can transfer to hospitals all around the city, the county. It was really meant to be a space for the community crisis system and the community mental health system to come together. So there's space in there, and then over the life of the building, there's been various co-located community programs. So for example, another peer-run agency has a post-crisis wraparound program that does like transportation or helps people get IDs and things like that. And so they have space in there. We have like external partners come in to do things like pet therapy and you know, we're hippies down in Tucson, things like that. And it's part of a cool campus. It's adjacent to what is basically the county hospital for Pima County. So it's, which is now, used to be the University of Arizona Health Network. Now it's Banner University. Medical Center South Campus. There's an ED, which I need to fix that, level 3 trauma center. But there's an emergency room right there with a breezeway that connects us to that ED. The bond also built a 66-bed inpatient psych hospital that is run by Banner, that is right adjacent, that's also connected via that breezeway. Our building has the crisis call center, which is run by a different agency, but it's in our building, and that's where they do all of the phones for the whole southern Arizona region. They get about 1,000 calls a month and resolve about 80% of those on the phone. If they can't resolve those, they have the ability, they do centralized dispatch for the various agencies that have mobile teams with GPS tracking and all kinds of fancy stuff. And so they dispatch the mobile teams, and the mobile teams can resolve like about 70% of the crises in the field, and then if they need to, they can bring them to us. And then the bond also built the mental health court, which is right there also. So most of the civil commitments happen on this campus, and so we can all do our court stuff there. They also do some low-level, like criminal warrant resolution stuff there. And it's funded, so the county owns the building. The way services are funded in Arizona is have been a managed Medicaid state since we ever had Medicaid. And so they divide the state into regions, the north, the south, and the central, and each region has a regional behavioral health authority that contracts with the state and gets all the Medicaid funds and stamps the block grant funds and state general funds and crisis funds and county funds and braids it all together in contracts with various service providers like us. And then they coordinate it centrally. This is, and when people talk about designing crisis services and doing things like this, you hear a lot about CIT, and a lot of people think that CIT is the training, which is a huge component of CIT. But if you actually go back and dig up the old CIT, like original stuff from like back in the 2000s, early 2000s, actually it's more of a community response. It's not just a training. And if you tell officers, if you're going to train them on how to recognize mental illness and say divert them somewhere else besides jail, their first question is going to be divert to what? And so they actually talk about like what would the ideal receiving center look like for law enforcement, and that's pretty much what our clinical model is. And so these 6 things is what was in their original white papers, and I highlighted the middle 2 because we do consulting and stuff around the country, and those are the 2 that we see people struggle the most with. They're the hardest to do well, and that's not having clinical barriers to care and a minimal turnaround for law enforcement. And so what do I mean by minimal barriers to care? Well, they kind of say that it's easier to get into heaven than a psychiatric facility because you can't be too drunk, you can't be too agitated, you can't be too mean, you can't be too this, you can't be too that. So we don't do that. Our philosophy is that we take everybody. We never turn law enforcement away. People always ask, well, then what do you do if they're medically unstable? And law enforcement's actually better than you would think at determining who really needs to go to an ER versus a crisis center. But even, I joke with Jason, I'd prefer you not bring me somebody unconscious. But if that does happen, like what makes the most sense? To turn them away and say, hey, non-medically trained law enforcement officer, put this medically unstable person that I just deemed medically unstable in the back of your non-medical patrol car and then drive them off the property to somewhere else and something bad happens to that person. Is that more risky than saying, okay, we're all going to be trained in basic life support and then we bring the person in and have a protocol to get them transferred to the emergency room as quick as possible? So that's what we do. We take everyone. As far as the agitated people, we like the agitated people. We want them here with us. Some people will say, well, we want to be they use the term recovery way to mean that we're not going to, it ends up being turned into not being able to take agitated people, saying, well, we don't want to do any hands-on or have any capacity to do, say, seclusion and restraint, which we don't do very much seclusion and restraint. We're actually lower than the inpatient national averages, but because we have the ability to, we're able to take anyone no matter how acute. Otherwise, you end up with places that'll say, well, we can't take anyone who might need seclusion and restraint, and that bar just keeps moving lower and lower until it's like they gave you the side eye, then they can't come. And then what happens to that person is that they end up, the law enforcement has to take them to the emergency room where they don't have the capacity to work with these folks, and they end up getting restrained anyway, or they end up in jail. So that's kind of our philosophy on being able to take everybody. Studies show that when you have a well-functioning law enforcement facility, receiving facility, that arrests go down, ER boarding goes down, and people going to inpatient psych goes down as well. So the second part is the easy access for law enforcement. So our philosophy is that if you're trying to, part of the mission is to get people out of jail or not having them be arrested and taken to jail. It's the law enforcement officers that have the patients. So therefore, they're our customers just as much as the patients are our customers. And so we work a lot with our law enforcement partners and meet with them, and they were involved in the design of the building. And what do they want? It's kind of simple. They need their own entrance. They need to get in and get out as quick as possible and not have people hassle them about taking their gun off. And that's pretty much it. So the CRC has this really cool gated sally port where officers come and they buzz a little button and it opens the gate and closes behind them. So if the person were to try to leave, it's like secure. And then they've got their own entrance area. So they then, when they buzz the buzzer for that door, that triggers our admission team to come meet them, which is like a nurse and a tech and a peer. And then the goal is to get them out as quick as possible. I mean, it's like, this is Joe. He was walking along the side of the road, throwing rocks at cars, says he's hearing voices, and he goes to this clinic. Like, that's all we really need out of the officer, and then they can go. And the other thing is before we kind of set it up this way, they'd be walking around because they need to make a copy or they need to go to the bathroom or get some water or whatever. Instead of walking around the clinical areas with their guns on, and then our staff would have to ask them to take their gun off, and they don't like that. So we got them everything they need back there. They have their own bathroom. They have their own little office where they can do all their paperwork and stuff. And we have it's hot in Arizona, so we've got some nice cold water for them. And so that way they can get everything they need done back there and get in and out. And our target, we were told it takes 20 minutes to book someone into Pima County Jail, which is a lie. It takes longer. But our target is 10 minutes or less for the adults and 20 minutes or less for the kids, because kids are more complicated. And so that is, we get them in and out as quick as possible. As far as what happens with the patients, so this is our observation unit, and the goal is to provide a safe and secure and therapeutic environment. It's an open area. It's not like a bunch of little rooms like you would see in an emergency room. That's for a couple of reasons. One is if you're trying to keep people safe, you need to be able to observe them all the time. So it's an open area so our staff can see everybody all the time. It's recliner chairs because they're really only there for 24 hours. We have it, set up so that it's safe, so people don't have the means to hurt themselves. The other reason it's open is because if you think about what happens in an ER, and they put you in a room by yourself, they have a sitter with you who's supposed to not talk to you about why you're there, and you stare at the wall for 12 hours waiting for an inpatient bed. And that is not very therapeutic. Like before we even had meds, the old psych hospitals, they had what was called milieu therapy, where just people interacting with each other in and of itself is therapeutic, which we still do on our inpatient unit. So they're assigned a spot, but they get up and walk around. We have peers who are doing groups and things like that. And then because the other thing why it's open too is because then we can flex our volume, because we never say no to law enforcement. So we're licensed for a certain number, but if law enforcement is bringing us people, we'll go above because we never turn them away. So the 23-hour observation unit, like I said, is kind of the heart of what we do. So here it's an interdisciplinary team that really starts to aggressively work with that person. We kind of shift our culture, like no matter how acute someone is when they come in, we don't assume they're going to the hospital. We assume that we're going to put them in our OBS unit and then work with them and resolve the crisis. And then after that 24 hours, only if we couldn't resolve the crisis do we pursue inpatient placement or other higher level care placement. And we do that via interdisciplinary team. So 24/7, we have psychiatrists, nurse practitioners, or PAs on site. We have a lot of peers with lived experience, so that's them in the picture there. They run groups, do a lot of one-on-one stuff with people. We've got 24/7 nursing. We have a lot of people on detox protocols, or we start Suboxone as well. We have behavioral health technicians. We don't use security on our units. It's our behavioral health techs that have a whole lot of training on de-escalation, and then if they need to do other ways to manage people, they can do that, but no security. And then our therapists and unit coordinators, they're working with people and working with families and trying to figure out what's going on and how to get them connected to their clinic and things like that. We've found we're data nerds, and so we've found that like the one data point that kind of makes the most difference is our door-to-doctor time, which is the time from when they come in to when they see one of our providers, because we found that the earlier that treatment is started, the better in terms of them being able to go home after 24 hours, in terms of them not needing to have restraints or assaults or injuries or anything like that. So getting them what they need as quick as possible is key. And then we collaborate, like I said, a whole lot with our community partners. We have this regional behavioral health authority system where there's sort of like a benevolent overlord that's like the single payer for a lot of the mental health stuff, and then the other health plans that do some of the other stuff. So we work with them a lot to make sure that we're getting our needs met in terms of the clinics and stuff being responsive for discharge planning. This is some data. So this shows the law enforcement drops every month, and the circles are the turnaround time for how often the officer gets in and out. So 10 minutes is our target, which is where we're usually at. And then the striking thing about this is that most places because we do this, we have a much larger facility up in Phoenix. We've done this in Texas and in other states, and most places, when the officers bring you someone, they're on whatever your emergency hold is, like your, pink slips or 5150s or whatever you call them in your state. In Arizona, or in Tucson in particular, 2/3 of who law enforcement brings us are voluntary, which really is a testament to how they really are engaging with people and saying, hey, would you like a ride to the crisis center? They're not handcuffing these folks. They're basically, one of our docs calls it the Uber police, but they really are really connecting people to treatment. And so that's bared out in the data that just shows, like, year after year after year, there are more and more people being taken to treatment, which, the question is this a good thing or a bad thing? And we think for the most part it's a good thing, because we have a whole separate process to look at people who we're cycling through multiple times. We call them our familiar faces. But what we're seeing is, like, most of the people that are being brought to us are not those people. It's, people who are needing to be hooked up with services. So just to end my part, the crisis, I talked about our crisis center, but I alluded to lots of other parts of the crisis system. So it really is a continuum. This is an old slide from SAMHSA that I stole a long time ago, but it talks about how there's the crisis response with kind of what we do, but then there's post-crisis wraparound, a lot of pre-crisis stuff, especially like having like crisis lines and mobile teams to respond and things like that. And so we have a very nice, robust crisis continuum down in Arizona that's been developed really over the last 20, 30 years. If you look at law enforcement, there's a CIT model, the Memphis model, which of course is sort of like the gold standard. There's other cool models that have been developed more recently, like LAPD has the co-responder model. But if you really think about it, like, they're mostly focused on this point of the crisis response, and then some follow up afterwards. But so after things have escalated to the point of crisis. So Jason's going to talk about some of the work that Tucson's done to kind of build up the services over here in sort of the pre-crisis and being more proactive and preventative. I'll have to give the little ball to you. Okay.
Tucson, Arizona Police Department, and also the Pima County Sheriff's Department. These programs started almost 7 years ago and have really grown over that time. But really we want to give just kind of a scale of how we started and grew. A lot of people I know out there are trying to figure out how to take the first step. And we've certainly come a long way. And the reality is that the Sheriff's Department out here and the Police Department, we started very small. We started kind of with this analysis that you're seeing on the side now of how do we balance these things, between a compassionate response to people with substance use disorder or mental health issues, and also our primary job as law enforcement, which of course is public safety. We kind of came up with this design here. Kate Lawson works in our criminal justice reform unit now, and has been involved with a lot of SAMHSA and GAINS projects, came up with this model here, and really it's kind of these overlapping goals that you see here. So for us as police officers, we kind of started with this mission statement here, which is we want to do the right thing for the person who's in crisis. We want to do the right thing for the officers and deputies, make sure that they're trained, make sure that they know how to respond to this, to these incidents, and really break the cycle of the criminal justice involvement that this population has. So we call our team here in Tucson the Mental Health Support Team. And of course, since we're cops, for some reason we made our acronym the biggest on this slide, right? But this is really what we try to do, is we try to be a small part of the glue that holds this plan or this system together for people who experience a crisis and then law enforcement becomes involved. One of the things that culturally, and I really appreciate the previous presenters for mentioning this, is this is really against the grain for law enforcement. I'd say we've come a long way in the last 6 or 7 years with CIT as a driver, particularly for cultural change for our officers and deputies. But really what we're asking these officers and deputies to do is not the normal thing. It's not what a lot of them have been originally trained to do, especially when you look at law enforcement professionals who have 15 to 20 plus years on the job. This is, we had to really do a cultural kind of recognition that many of you on this call, I can even see from the questions, you all have been doing this work, whether it's the treatment community, the courts, even probation. And law enforcement kind of responders, police and fire, the reality is we had to acknowledge that we were the ones missing from the table for decades, really. And we use CIT training, I'll talk about in a little bit, as a major driver for cultural change for our departments, our Sheriff's Department, our Police Department out here. I'll break down really quick what our mental health support teams in Tucson do. We have officers, detectives, sergeants, and then we have co-responders and outreach workers, which I'll discuss a little bit later as well. On the officer and deputy side, just very briefly, they are in charge of all of the, in a centralized way, in charge of all of the mental health, what we would, what many people would call from the lay perspective, the mental health pickup orders. In Arizona, we call it court-ordered treatment. In other places, I've heard it's called AOT, assisted, I think, outpatient treatment. But people that are involved in some way in the involuntary system, in the involuntary mental health. So people that are out in the community, an application or a petition or court order gets filed, we go out, we pick them up, and we take them to the hospital. Usually the crisis response center, like Margie just mentioned. Our detectives, on the other side, do a lot of follow-up. They work with our co-responders, clinicians. We give a lot of credit to LAPD. They have a great co-responder model. We copied much of their program, but we have embedded co-responders that help us prioritize cases and kind of do the deep dive follow-up for people that need more than just a brief intervention. This is a couple of our officers. You can see on some of the questions already. We drive unmarked cars. Yes, you can still tell they're police cars, but at least we've made the step. We don't do a lights and sirens response. To borrow a term from Dr. Bauer and Kate Vesley out here, we do what's called the low and slow approach. So we don't do lights and sirens coming to the door with a big, heavy police response. Low and slow is kind of our motto out here. There's a lot of information on this site, and just in the interest of time, I have a question about this either in our next chat. And we do voluntary CIT in Tucson, and we do follow the Memphis model. We have 100% of our personnel in mental health first aid. And if you want to ask questions kind of at the end about what's the difference between those two, mental health first aid is kind of the 8-hour training that is just a familiarity course. It's a very good class, and we put it right in our academy. So I've trained all of our existing personnel. And then we have the full 40-hour voluntary CIT. About 65% of our actual first responders to 911 calls are CIT trained. So we're definitely following, the voluntary model. And then we have advanced training for our mental health support team officers as well. A little bit more information about our CIT program. We work very closely Arizona Complete Health, which is our regional behavioral health authority. It's a huge positive influence and a partner. Most of the stuff that we do, we could not do without them and with Dr. Balfour at the Crisis Response Center. Our CIT is really interesting from a law enforcement perspective because about 80 to 85% of our 40-hour week is taught not by police officers, but by the treatment community, by attorneys, by doctors like Margie on the call right now, by NAMI, by people who have lived experience, by peers, by behavioral health professionals. And that's really unique for us, but we really value that feedback from the actual communities that we're trying to serve. This is just, the numbers are always important, right? And so one of the things we try to do as best we can as law enforcement out here in Tucson and in Pima County is track and kind of justify our team and the cost and how we save time for patrol officers. One of the things that, that we really strive for is to follow up with what you would, you might call the high utilizer or the frequent consumer, the person that's calling 911, 2, 3, 5, 10 times a week. That's the kind of person that can really not just but the 911 crisis line here is a huge. They actually and avoiding an unnecessary law enforcement response. This is just a graph that shows how we're serving the mental health pickup orders. We used to have all of them served by patrol officers, and now they're served, the vast majority are served by the dedicated mental health support team officers. And that's one of the big things I would mention here for anyone considering law enforcement and getting into this work. We're very lucky in Tucson that we have a chief of police that really made these resources dedicated and not designated. And anyone in law enforcement probably knows what I mean when I say that, because dedicated means they don't have to do anything else other than work on mental health and substance use disorder issues. So they're not in between the domestic violence or the burglary call or the car accident. They're really kind of professionals just dealing, really honed in to just dealing with this population. One of the things I kind of want to just wrap up here with is to understand that, we are trying to save time and resources, but this works without a real, genuine, no wrong door diversion center, and that's what we have with Dr. Balfour and the Crisis Response Center. When I started this work 6 or 7 years ago, we would go to law enforcement conferences, and the real push was, how do we get leaders in law enforcement to adapt the philosophy of diversion, of jail diversion, because really that's at the heart of a lot of what we do. And really we've come a long way, I must say, in this country in law enforcement. What I'm hearing law enforcement leaders talk to now, speak to now at conferences is, okay, we get the diversion, like we get the philosophy, but divert to what? I don't have that resource in my town or in my county. And so that's just a really significant issue. We're lucky in Tucson also, we are a learning site with the Council of State Governments. There is some funding available at a federal level for people to come out and tour our crisis center. Dr. Balfour does a great job at advising people how to stand up or maybe even apply for a planning grant to help start a crisis center where you are and how to make it viable for law enforcement. Really, none of the programs that we have here, whether it's our homeless outreach program, our substance use deflection program, or our mental health team, none of those would really work without a genuine diversion program, especially living in the time of COVID. One of the things I work on daily is homeless outreach, and doing that work in the time of what we're living under right now is even more difficult than it would be normally. And we're relying, as heavily as we ever have been on our system partners like our crisis center to really make that program viable and successful. And with that, I think I will turn it over to Dan.
Okay. Well, thank you, all our presenters. I think that, all the work that was presented today was very innovative. And I also think that, there was a lot of discussion about the culture shift that's required both on the part of law enforcement, as Sergeant Winsky said, but as Candace talked about, also on the part of the mental health system also, that if you're going to undertake this work, you have to pay attention to those culture issues, and that some of the values have to change. And I think you did a good job of talking about the interdependence of law enforcement and our crisis response systems. We have more questions than we're going to be able to answer. You already are quite familiar with the chat box, so let's take a few of the questions, and then we hope that most of you will join us for the discussion group, which I'll talk about later. So, so let me do some of the questions that will require a relatively quick answer. We'll go with Knoxville first and then Tucson. Do you both service developmentally disabled population?
The question again, Dan, sorry.
So there were questions about whether or not people with developmental disabilities are served in these programs.
Yes.
Okay, and Tucson?
Yes, we serve whoever the police bring us.
Yeah.
That said, we have a youth unit, so
Yeah.
That population is, of course, especially challenging, but we work with some of our system partners to make sure that we kind of have some special protocols for them and make sure, especially the ones who aren't very verbal, have like communication pads and things like that. But yes, we do.
Thanks. So there were questions about your 9 misdemeanor charges. I won't ask them for you now, Candace and Captain Jones, but there were some questions about how law enforcement being housed on your unit. So there was a question about whether or not the unit is locked, whether or not officers are in uniform, whether or not officers are CIT trained. If you can address some of those issues, Candace and Captain Jones.
Yes. The unit is not. It's locked going into it. Yes. So it is under the licensure in a behavioral health under that licensure. So it is not locked. However, the policing station is manned all the time there. And so if anyone tries to leave, then that officer will address and Captain Jones.
It's a quasi, it's staffed by the jail staff and the sheriff's department, and they're basically just there to intake folks, and then they're there in case they try to walk off, because our folks are actually been charged with the crime. So if they decide they don't want to be at the buck anymore, then we transport them to the jail.
Okay, thank you
And
very
law
much.
enforcement is not on the unit unless they are called to be on the unit, and that is initiated by staff.
Yeah, you referenced that would be an interesting discussion for the discussion group, because that culture issue was very important as you addressed it in your presentation. This goes to Tucson, Dr. Belford. It's certainly commendable that you take everyone, no refusal, and you've made adjustments and being able, and accommodations, being able to do that. And it's relatively unusual for crisis units to be that committed. So question is, how quickly can you respond to somebody who comes in who is acutely agitated and may need medication or very, very prompt intervention?
Yeah, so we have so either a psychiatrist or a nurse practitioner on site all the time. So if someone is coming in agitated, like we know immediately if they need to get one of us to order meds, then we're right there. I mentioned our behavioral health techs. They really deserve the credit for keeping the unit safe. You know, we train them. Like I said, we don't use security, but because our philosophy is if we're going to train our techs up so well, they're the experts in behavioral management. So then why would we default to someone with less training? And so we do therapeutic options, which is like a verbal de-escalation, trauma-informed training, which all of our staff gets, all the different disciplines, everyone gets. And then the behavioral health techs get something called Safe Clinch, which is the kind of the hands-on training. And again, like we're doing everything we can to avoid seclusion restraints, and our rates are lower than inpatient averages, but they're always prepared. And so they do drills and they practice. They go over difficult scenarios. Whenever there is an incident, we review the video. And the result of that is that they're very confident. And so when something does happen, it just sort of happens like a well-oiled machine, and they're able to, de-escalate that person or get them safely to where they need to be very quickly. And then if we need to do medications and things like that, we can.
Thank you very much, Dr. Belfour. So you see on your screen, and that will conclude the webinar. Again, I'd like to thank our panelists for a terrific presentation. You see on your screen that we have a document that you can download now by hitting the download tab, and this document is a question answer kind of format of both these programs. So some of the questions that were in the chat box can actually be answered by downloading this document, including the 9 charges for the Knoxville program that are included. So please download that. Now for those of you who will be joining us in the discussion following this, it will require that you hang up and disconnect from Adobe, and then redial in with this new link, which I believe our staff support will be putting in the chat box, because this particular link on the slide is not clickable. But in 1 second or two, we'll have the link for the discussion group go into the chat box. I'd like to remind folks, too, that in the discussion group, you will be able to answer questions from your phone, unmute your phone and answer questions, and use the chat feature. Amelia, do we have the link coming in?
It's up there.
It is in the chat a few times.
It is up there. Okay, I missed. Oh, there it is on top. Okay, I missed it. All right. So with that, then we'll conclude our this portion of the webinar, and we hope to speak to you again in a discussion group in about 5 minutes. Thank you.